first the introduction, the layers of the pleura. We'll talk about the pulmonary ligament. We'll talk about the recesses of the pleura. Then we'll go further to talk about the nerve supply, the blood supply, and the clinical significance. So let's go straight to the introduction. So what is pleura? The pleura is a serous membrane. The pleura is a serous membrane that encloses or surrounds the lungs. There are two lungs in our thoracic cage, present on both sides on the lateral components of the thoracic wall, and this pleura surrounds them, helping to protect them. And they are lined by some epithelial tissues called what? Mesothelium. This mesothelium, that epithelial tissue that lines the pleura. And what is their function? The epithelial tissue lining this pleura helps produce serous fluid that lubricates the pleura, reducing the friction between them and helps them to move without friction. So the epithelia, that is the mesothelium that is lining the pleura, helps to produce serous fluid, a thin clear fluid that helps to lubricate the pleura during respiration. So now we're going over to the layers of the pleura. The pleura has two layers: the visceral layer, also known as the pulmonary pleura, and also the parietal layer, that's pleura. So these are the two layers of the pleura. And this, in between these two layers, there's a space known as the pleural cavity. This pleural cavity is formed during embryonic development when the developing lung buds invaginate into the serous sac present in the thoracic wall. So when they invaginate, they form these two layers known as the parietal and the visceral pleura, and both layers are continuous with each other at the cuff of the pleura, which is at the roots of the lungs. Okay, the diagram above will show us the cuff of the pleura and the roots of the lung, where the parietal and the visceral pleura are continuous with each other. So now let's talk on the visceral pleura. The visceral pleura is also known as the pulmonary pleura, in the sense that it lines the outer surface of the lungs directly. It invests the entire surface of the lung, except at the hilum, that's at the root of the lung, where the pulmonary arteries and the bronchi enters or leaves the lungs. So the direct covering of the lung is the visceral pleura. That is why it is called the pulmonary pleura. And this visceral pleura is bound strongly to the lung. It extends into the depth of the fissures of the lung. When we talk about the lungs, you know that there are different lobes of the lungs, and in between the lobes, there are fissures of the lungs. So this visceral pleura extends into the depth of the fissures of this lung. That is why it is bound tightly to it, and it is not separable easily. So this is all about the visceral pleura. And let's talk about the parietal pleura. The parietal pleura is it is the outermost covering of the lungs. That is, it does not directly cover the lung, but it is separated from the visceral pleura by the pleural cavity. That is, the pleural cavity serves as an intermediate between the visceral pleura and the parietal pleura. The diagram above shows parietal pleura and the visceral pleura. Now, this parietal pleura, it lines the thoracic wall and the mediastinum, that is the pulmonary cavity. How? It is adjoined to them by By a loose areolar tissue, which is known as the endothoracic fascia. The endothoracic fascia helps the parietal pleura, to line the thoracic cavity and the mediastinum, which is the pulmonary cavity. So this endothoracic fascia, in living humans, the endothoracic fascia is easily separable from the thoracic wall. Then now, we know that we have talked about the layers of the pleura, that is the visceral and the parietal pleura. Now let's go over to the subdivisions of the parietal pleura. This parietal pleura has 4 subdivisions, which are the costal pleura, the mediastinal pleura, the diaphragmatic pleura, and the cervical pleura. These are the 4 subdivisions of the parietal pleura. Now, for you to be able to memorize these divisions, their name is just corresponding to their location. So their name is related to where they are found. Like the costal pleura is related to what? The costal cartilages, the ribs, and the intercostal spaces. That is on the thoracic wall. While the mediastinal pleura is related to the what? Mediastinum. That is, it forms the lateral boundary of the mediastinum. And also the diaphragmatic pleura is located inferiorly. That is, in relation to the diaphragm. It lines the superior surface of the diaphragm. And also the cervical pleura is extending into the root of the neck. That is why it is called cervical pleura. So let's discuss them individually. Costal pleura. The costal pleura, it is the part of the parietal pleura that lines the thoracic wall, including the ribs, the intercostal spaces, and also the costal cartilages. Yes, that's what they line. Then let's talk about the diaphragmatic pleura. The diaphragmatic pleura is located inferiorly. Yes, inferiorly. It lines the superior surface of the diaphragm. That's the dome of the diaphragm. It lines the superior surface of the diaphragm. And during quiet respiration, the diaphragmatic pleura and the costal pleura, they are in opposition to each other at the lower or inferior border of the lungs. Now let's talk about the mediastinal pleura. The mediastinal pleura, it is the pleura that lines the corresponding parts of the mediastinum. That is both on this side and on the right side. Yes, it lines the corresponding part of the mediastinum. It forms the lateral boundary of the mediastinum. That is what point, the one point you should take note of. It forms the lateral boundary of the mediastinum. Yes. You should also take note that it is continuous with the visceral pleura. It is continuous with the visceral pleura. And you know that the visceral pleura is the direct covering of the lungs. Now let's go over to the cervical pleura. The cervical pleura is also known as cupola. 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 It is surrounded by the suprapleural membrane. I know that the suprapleural membrane forms the diaphragm of the superior thoracic aperture. That is the suprapleural membrane. Then this cervical pleura. The cervical pleura covers the apex of the lungs. You know that the apex of the lung is located superiorly. It extends into the root of the neck. It covers the apex of the lung. And let us take note that the cervical pleura is the dome of the parietal pleura. It is the dome of the parietal pleura, and it extends into the root of the neck. Extends into the root of the neck about 1 inch above the medial end of the clavicle and about 2 inches above the first costal cartilage. Now, let's go over to the relations of the cervical pleura. This cervical pleura is related anteriorly to this subclavian artery and also to the scalenus anterior muscle. That is the two anterior relations of the cervical pleura. Then the posterior relation of this cervical pleura is the neck of the first rib. The neck of the first rib, that is the posterior relation of the cervical pleura, and structures passing in front of it. And what are these structures passing in front of this neck of the first rib? They include the ventral ramus of the first thoracic nerve, and the first posterior intercostal artery, the first posterior intercostal vein, and also the sympathetic chain. These are the four structures that passes in front of the neck of the first. The lateral relation of the cervical pleura. It's just the scalenus medius muscle. It is related laterally to the cervical pleura, the scalenus medius muscle. And the medial relation, it's just the great vessels of the neck. The great vessels of the neck are related medially to the cervical pleura. Now let's go to the pulmonary ligament. The pulmonary ligament is the part of the cuff of the lungs, the cuff of the pleura of the lungs, that extends downward as far down to the diaphragm, in between the lungs and the mediastinum. It can be represented by the sleeve of a jacket. The sleeve of this lab coat now looks exactly like the cuff, like the pulmonary ligament. If this is the cuff of the pleura surrounding the roots of the lungs, then this part of the cuff that hangs down forming a triangular fold like this. It's called the pulmonary ligament, and it is filled with what? With few lymphatics. It is filled with some few lymphatics, and it helps to what? Now, like I said, the triangular fold which forms what? The pulmonary ligament is filled with some areolar tissues and few lymphatics. Now, the functions of the pulmonary ligament. The pulmonary ligament serves as a dead space to which the what? The pulmonary veins expand during increased venous return. For instance, during exercise, your body tissues, your muscles, they need oxygen. And what happens? The pulmonary veins, which carries what? Oxygenated blood from the lungs, expand in order for there to be what? Increased what? Venous return. So, another function that we can point out is that it helps what? The pulmonary ligament helps in the descent of the diaphragm and also the descent of the lungs. What do I mean by that? That is, during inspiration, when you inspire, your diaphragm descends, and also before that, the root of the lungs also descends. So it is this pulmonary ligament that gives a space, that provides the avenue for this descending to occur. Okay, that is the function of this pulmonary ligament. And also, we have to know that the apex of the lung also descends, leaving an empty space above the suprapleural membrane that encloses it. So, after you've inspired, while you want to expire, it also expands into the space, to the empty space below the suprapleural membrane. Now, let's talk about the recesses of the lungs. The lungs have some expanded spaces. Now, let's talk on the recesses of the pleura. So, what are the recesses of the pleura, or pleural recesses? They are just expanded spaces within the pleural cavity. The pleural cavity is in between the two layers of the pleura, which is the visceral layer and the parietal layer. So, in between them, there's a space known as what? The pleural cavity. So, this pleural cavity, there are some specific regions that are expanded, helping with the expansion of the lungs during respiration. That is, they serve as reserve spaces for the lungs to expand during respiration. And what are these recesses? They are two in number: the costodiaphragmatic recess and the costomediastinal recess. The costodiaphragmatic recess and the costomediastinal recess. You can see them on the diagram above. Now, there are other recesses, but these are the two major recesses. Others include the retroesophageal recess and the infracardiac recess. But these costodiaphragmatic and costomediastinal are the one we are focusing on. Then let's talk about the costodiaphragmatic recess. Like we can see on the diagram above, the costodiaphragmatic recess is located posterolaterally, and it's vertically, it measures 5 cm, and it lies opposite the 8th and 10th rib. It lies opposite the 8th and 10th rib. Take note of that. Along the mid-axillary line, not just opposite the 8th to 10th rib. It lies along the mid-axillary line. That is, if you want to know the position of the costodiaphragmatic recess, it traces from along the mid-axillary line opposite the 8th and 10th ribs. Now, the costomediastinal recess. The costomediastinal recess is located anteriorly. It's located anteriorly between the costal and the mediastinal pleura. And you should also know that the costodiaphragmatic recess, like we mentioned before, is between the costal and the diaphragmatic recess. Pleura. The costal and the diaphragmatic pleura, here. The costal and diaphragmatic pleura. That is, that the costal pleura is related to the thoracic wall, and the diaphragmatic pleura is related to the diaphragm. That is, it lines the diaphragm. So, in between them, there is a expanded space there, just like we've seen in the diagram. There's a expanded space there. That is the costodiaphragmatic recess. Now let's go back to costomediastinal recess. Between the what? The costal and the mediastinal pleura. That is between the sternum and the costal cartilages. Yeah. And it's also important to note that the most dependent part of the pleural cavity is the costal diaphragmatic recess. The costal diaphragmatic recess. That is why the fluid of pleural effusion first collects at that site. Yes, the first site at which the fluid of pleural effusion collects is at the costal diaphragmatic recess. We will discuss pleural effusion when talking about the clinical significance. Yeah. Now, back costomediastinal recess. The right costomediastinal recess is possibly occupied by the what? The anterior margin of the right lung. So, but the left costomediastinal recess is larger due to what? The cardiac notch that is present in the left lung. And we can confirm this thing clinically by what? By percussion, by tapping. When we tap the right part of the costomediastinal recess that is occupied by lung tissue, like we have said, the tone is different from that of the left one that is unoccupied by the lung tissue. There is a change in tone when we tap from the right to the left, which is from resonant to the dull. And what is this called? It is called the superficial cardiac dullness. Take note of that. Superficial cardiac dullness. Now, we've talked about the recesses, and we are going over to talk about the nerve supply to the pleura. So, the nerve supply to the visceral pleura is different from that of the parietal pleura. The parietal pleura is supplied by the somatic nerve fibers, while the visceral pleura is supplied by the sympathetic nerve fibers. That is autonomic nerve fiber. Yeah. Let's talk about the somatic nerve fibers that supply the parietal pleura. The somatic nerve fibers that supply the parietal pleura are the intercostal nerves and the phrenic nerves. Yeah. The intercostal nerve and the phrenic nerves are the nerves that supply the parietal pleura. And this is why the parietal pleura is sensitive to pain, because it is supplied by the somatic nerve fiber. Unlike the visceral pleura that is insensitive to pain, because it is supplied by autonomic sympathetic nerve fiber. Here. And these autonomic sympathetic nerve fibers that supply the visceral pleura are the T2 and the T5 nerve fiber. Now let's go over to the blood supply. The blood supply to the pleura. The blood supply to the parietal pleura is same as the blood supply to the thoracic cavity, the thoracic vein. Yeah. And the blood supply to the visceral pleura is same as the blood supply to the lungs. Of course, that's the pulmonary artery. Now, let's go over to the difference between the visceral and the parietal pleura. I think I omitted that in the headings I gave you. Well, let's just look at the difference between the two layers of the pleura briefly. First of all, we have to know and take note that the visceral pleura is insensitive to pain, but the parietal pleura is sensitive to pain due to what? The fact that the parietal pleura is supplied by somatic nerve fibers. Then we also ought to take note of the fact that the visceral pleura originates or develops from what? The splanchnopluric mesoderm. Splanchnopluric mesoderm. While the parietal pleura develops from the somatopleuric mesoderm. And we should also take note of their lining. Yeah. The parietal pleura lines the thoracic cavity, while the thoracic cavity and the mediastinum, while the visceral pleura lines the lungs. Yeah, you should take note of that and some other differences. Now let's go over to the clinical significance. Whenever we discuss any topic on anatomy, it is necessary for us to talk about the clinical significance or the applied anatomy. Now, the applied anatomy for this pleura, one of them is inflammation of the pleura, which is pleuritis. Pleuritis is simply just the inflammation of the pleura. So the pleuritis that we're talking about has to do with the inflammation of the pleura. Yeah, inflammation of the pleura. And the inflammation can be due to accumulation of some inflammatory exudate. It can cause inflammation, roughens the pleura and inflames it. And this inflammation can clinically present as pain. Yeah, pain. You feel pain because of this inflammation, and the pain is aggravated when you respire. Yeah, continuous respiration aggravates increases the pain as you feel during this when you are affected by this inflammatory exudates that inflames the pleura. Now let's go over to the next one, pleural effusion. I mentioned this pleural effusion before when I was talking about the costodiaphragmatic recess. The costodiaphragmatic recess is the most dependent part of the pleural cavity that fluid effusion can collect first. Yeah, pleural effusion is simply the accumulation of fluid at this point that the pleural cavity is expanded, just like the costomediastinal and costodiaphragmatic recesses. So some fluid can accumulate there, which is known as pleural effusion. Yeah, and not just fluid, there are some other things that can also accumulate, such as air. And when air accumulates, it is called pneumothorax. And also take note that this pleural effusion is also called hydrothorax. That is accumulation of fluid within the pleural cavity. Accumulation of air is pneumothorax. And pus can also accumulate, which is pyrothorax. So let's do another one, another clinical significance, which is thoracocentesis. Thoracocentesis or pleural tap. This is a procedure by which fluids within the pleural cavity are aspirated. You understand? Some substances within the pleural cavities are aspirated, and it is done by inserting the needle at the sixth intercostal space. The sixth intercostal space along the mid-axillary line, and not just at the intercostal space, at the lower border of the intercostal space, that is at the upper border of the rib. That's in this case it should be seventh rib. Yeah, the sixth intercostal space is between the sixth and the seventh rib, so it's at the upper border of the seventh rib. Why? In order not to injure some intercostal vessels and nerves present. That is why you should be very, very careful when taking this procedure. Yeah, and the list of the structures that you're going to penetrate in succession are the skin, the superficial fascia. You're going to penetrate the superficial fascia, the serratus anterior muscle, the intercostal muscle. Then, before penetrating the intercostal muscles, then you get to the endothoracic fascia. Then, after the endothoracic fascia, then you can now penetrate the parietal pleura before the fluid can be aspirated. That's the end of our class today. So thanks for watching, and don't forget to subscribe to our channel for